Hello, my name is Yejin Hong, and I'm a medical student at the University of Calgary, and our team is here to explain inflammatory bowel disease as a link between ophthalmology and gastroenterology. There is currently active research going on to find out the positive correlation between patients with eye disease, such as uveitis, and GI symptoms, such as inflammation along the walls or even bleeding. The novel idea, called the gut-eye axis, is currently drawing new links between the gut microbiome and ophthalmic conditions. Different diets can alter the composition of gut bacterial population, and depending on the species, the bacteria can produce proteins upon metabolizing objects that pass the GI tract. These proteins can act as inflammatory markers for the immune cell to interact with and trigger a cascade of responses. We will cover this in more depth soon, but systemic inflammation can also affect the eyes as well. Certain presentations in the GI can activate inflammation in the eyes. Specifically, anterior uveitis has been shown to correspond with the incidences of GI symptoms. As shown here, there's a layer between the retina and the sclera called the choroid. Choroid is the posterior part of the uvea, and the anterior uvea that we're talking about in anterior uveitis includes the iris and the ciliary body. Inflammation in these anatomic parts is caused by inflammatory bowel disease, or IBD for short. IBD is a chronic and idiopathic immune-mediated diseases of the GI tract, and mainly it can be classified into Crohn's disease or ulcerative colitis. If there's a presentation that seems to be a mix of these two, or if it's hard to differentiate according to the patient's presentation, it can be classified as IBD-U as well, or IBD unclassified. Many environmental and genetic factors can contribute to an individual developing an IBD. This happens more frequently in youth population and can also have a genetic predisposition. However, there's no one specific gene that can be pointed at as a cause of IBD, but instead it is a polygenic risk factor. In twin studies, monozygotic twin concordance for ulcerative colitis was 15%, while Crohn's disease was 30%, so there is some relation to genetics. Further studies need to be conducted, but it is thought that these genes have a degree of control over innate immune system. Certain lifestyles, such as smoking, being obese, or having obesity, I should say, and being exposed to a polluted environment, and sometimes being exposed to the UV rays, and therefore having excess vitamin D in the system, can raise the risk of IBD, and certain medications such as NSAIDs, antibiotics, and oral contraception can raise the risks for IBD as well. We have split the symptoms and signs into that of ulcerative colitis, Crohn's disease, and extraintestinal manifestations. We'll go through them one by one. So first, for ulcerative colitis, there may be a sense of urgency to go to the bathroom, although you might not have anything to defecate from the rectum in the first place. Tenesmus is a symptom of the sensation of not being able to empty your bowels after having defecated in the toilet. Abdominal cramping can also present with or without pain. Diarrhea can be included as the inflamed GI tract tries to evacuate the waste faster. And this diarrhea is frequent, like going to the bathroom more than 10 times a day. It can be low volume, nocturnal, going to the washroom at night, and it's bloody. Inflammation can also give off systemic symptoms such as weight loss, fatigue, and fever. Crohn's disease, similar to ulcerative colitis, can also present with abdominal pain and diarrhea. It can also present with the systemic symptoms associated with inflammation in the GI tract. Crohn's disease is not continuous, meaning there are ulcerations intermittently from gum to bum. These types of ulcerations can include cobblestoning, serpiginous, and aphthous pathologies. Because it affects the whole length of the GI tract, GERD can be present, or gastroesophageal reflux disease. And nausea, early satiety, bloating, and distension can also be present. Perianal abscess and fistula can form, and when the fistula connects the bladder and the rectum, pieces of defecation products can be seen in urine, as well as some of the air bubbles. Finally, there are some manifestations in cases of IBD that are not within the GI tract itself. We have separated them into oral, ocular, dermatological, and in joints. In the mouth, there can be ulcers, stomatitis, and angular cheilitis. In the eyes, as we will explore further, there can be inflammation throughout, so uveitis, scleritis, and episcleritis. On the skin, you can find wide red spots called erythema nodosum. Pyoderma gangrenosum can also occur. And rarely sweet syndrome can accompany IBD. This is a very rare inflammatory skin condition, and presentation involves a sudden spike of fever, plus painful rash on the arms, legs, face, and neck, as well as the back. Type 1 arthropathy is asymmetric and involves less than 5 joints, while type 2 is symmetric and involves 5 or more small joints. And polyarticular, meaning that different types of joints are involved. Axial arthropathy involves the joints in the central axis of the body, including sacroiliac joints. Ankylosing spondylitis is another comorbidity that can occur with IBD, and this involves low back pain, morning stiffness that gradually resolves throughout the day, and the pain gets worse with rest and better with activity. Enthesitis and tenosynovitis can also occur. Enthesitis is the inflammation of tendon or ligament as they insert into the bone. And tenosynovitis is the swelling of the sheath surrounding a tendon. Here is the comparison chart between ulcerative colitis and Crohn's disease. The way I remembered it is because Crohn's disease has a possessive apostrophe S, I pictured a man named Crohn. And this is a hardworking man that shovels the wall of the intestinal tract all the way from the mouth to the rectum. And when he starts shoveling, he goes all the way. However, because he is just a man, he can't work on the entire length, and instead skips a few areas so he can concentrate his efforts on just a few throughout the whole length. Anyways, According to that analogy, chronic Crohn's disease affects the inflammation transmurally, which implies throughout the entire thickness of the GI tract wall, while ulcerative colitis only affects down to the mucosal layer. UC is also quite localized to the bum part, or rectum and the colon, while Crohn's disease affects throughout gum to bum. Because of its transmural nature, there's a higher likelihood of fistula or stricture developing in Crohn's disease. And bleeding is common in ulcerative colitis, while in Crohn's, the bleeding only occurs sometimes. Feel free to pause the video and take some time to go over each of the comparisons in this table. IBD is a chronic disease, so when getting the history from a patient, the patient may know a great deal about their disease. So never hurts to ask them about the previous and the current treatment, as well as the most recent disease staging they've heard. Upon abdominal physical exam, it's important to localize the pain, the intensity, location, or duration. Also, if the pain is over a broad area or radiates somewhere, if it gets worse with a certain activity or event, like a certain type of food, definitely note that. Stool frequency and diarrhea is also an important part of history. And rule out rectal signs and symptoms that we've covered before: urgency, tenesmus, bleeding, any discharges, and also upper GI symptoms like early satiety, reflux, and bloating. Also rule out systemic symptoms like recent weight loss, depression, anorexia, and dysmenorrhea. There are multiple investigation options for IBD. First, CBC and light, including magnesium, potassium, calcium, and also checking for blood pH is crucial. And check the CRP, because this is an inflammatory marker in the blood. If there's constant bleeding from the GI tract, rule out anemia with ferritin and iron. And the level of albumin in the blood indicates the nutritional status of the patient, which is important because GI tract is in charge of absorbing essential nutrients for the body. For Crohn's disease, investigate for ASCA, or anti-Saccharomyces cerevisiae antibody, and for ulcerative colitis, p-ANCA antibody. For direct viewing of the tract walls, we can perform double balloon enteroscopy, capsule enteroscopy, and take direct biopsies from the GI tract walls. And CT and MR enterography can be done as well. The treatment involves usually a step up or step down approach of this pyramid. Usually, for ulcerative colitis, a step up, starting from aminosalicylate and antibiotics, going up to steroids, immunosuppressants, biologics, then surgery. And for Crohn's disease, is usually the opposite, starting from the surgery to isolate the intermittent areas of inflammation and trying our best to preserve the non-affected parts, and going down to biologics, immunosuppressants, steroids, and then antibiotics and aminosalicylates. For each levels within that pyramid, there are induction and maintenance methods. And that varies according to whether the disease is ulcerative colitis or Crohn's disease. Take a look in the table to see which of the management options are qualified for each disease, and whether if there is any restriction on the induction or the maintenance options. As we have covered already, GI or IBD can modulate the inflammation of the eye, specifically the anterior uvea, or the iris and the ciliary muscles, and posterior uvea, known as the choroid, which is between retina and sclera, can develop inflammation called uveitis. So here is the big research slide of this presentation. The pathophysiology of IBD-induced anterior uveitis is first caused by the reconstitution of the gut microbiome. This is usually accomplished by high-carb diets. What we eat usually determines the population composition of different bacteria in our gut, because there are specific species that survive better on different types of diets. With high-carb diets and the microbiome that are reorganized from it, the certain proteins increase in production in the gut by those bacteria. The examples of such microorganisms that produce the proteins are Bacteroidetes, Firmicutes, alpha proteobacteria, and gamma proteobacteria. The proteins, incidentally, some of the peptide products they create are similar in structure to the protein in the eye, interphotoreceptor retinoid binding protein. I'm sure there are a lot more variety and a lot more different matches between the gut and the eyes proteins, but this is one of the representative ones that we have been able to identify from the papers. So T lymphocytes begin the inflammatory cascade upon coming across the abnormal bacterial protein in the gut. Because the gut wall is undergoing systemic inflammation throughout, it also becomes more permeable, allowing more of these immune cells to come through and detect these proteins. So T lymphocytes begin attacking the IRBP in the gut and also in the eyes, because it has similar epitopes or recognizing points with the inflammatory proteins. With ulcerative colitis, there is approximately 5 to 10% of attaining anterior uveitis, and in Crohn's disease, it is more common. While smoking does have a protective effect against ulcerative colitis, it raises the risk for anterior uveitis. With the GI-derived anterior uveitis, the patient may have red eyes, pain and photophobia, tearing, and decreased vision or floaters if the retina is also affected. Because of its systemic nature, IBD can cause bilateral anterior as well as posterior uveitis. It can also cause miosis or the narrowing of the pupils, cells and flares in the AC indicating the anterior inflammation, ciliary injection, keratic precipitates in the cornea, and also inflammation of the cornea or keratitis. That may decrease corneal sensation, and in the iris, which is part of the anterior uvea, the nodules may form or the structure itself may atrophy. Posner-Schlossman syndrome, or episodes of increased intraocular pressure plus anterior chamber inflammation, can also present with anterior uveitis by IBD. Hypopyon, or the presence of inflammatory cells in the form of white exudates at the bottom of the anterior chamber, can also be seen. If it invades the retina as well, cystoid macular edema and optic disc edema could develop, rarely. Other ophthalmic complications of IBD includes dry eyes and scleritis and episcleritis. The layer on top of the sclera, called conjunctiva, can be inflamed as well. And as you can see in the bottom far left picture there, orbital cellulitis can occur, as well as optic neuritis, which is the inflammation at the optic nerve. This presentation is not limited to just IBD-induced anterior uveitis. It could also be from retinal detachment, retinoblastoma, and malignant melanoma. For younger patients, juvenile xanthogranuloma and intraocular foreign body may cause these presentations. Ocular ischemic syndrome, which is caused by ipsilateral carotid occlusive disease and presents when 90% of the carotid artery is occluded, can be the culprit as well. Lastly, toxoplasmosis, caused by Toxoplasma gondii, an obligate intracellular parasite protozoa, can be another form of diagnosis other than anterior uveitis. When looking at the eye with patients with IBD, take complete history with attention to past herpetic keratitis or trauma. Pay attention to any collagen vascular diseases, autoimmune, and infections. Ask about what medications they're taking, as well as the main composition of their diet. Do they take raw meat? Do they drink unpasteurized milk? Have they traveled recently to any third world countries and indigenous areas? And have they been exposed to cats or dogs, or do they have a pet? Do a thorough review of systems from the skin, mainly observation. Look at the joints and whether the patient has full range of motion. Lungs, listen for crackles. And the GI abdominal exam, neurologic, such as pinprick sensation, temperature, localization of any stimulus, and reflexes. For the eye specifically, check for corneal sensations. On the slit lamp, locate any keratic precipitates and check for the pressure of the eyes. Pay specific attention to anterior chamber for any signs of cells and flares, iris for any atrophy and nodules, and vitreous cells. Investigations for such anterior uveitis includes basic CBC and the inflammatory ESR marker, and also the workup for syphilis, which includes VDRL, venereal disease research laboratory test, and a fluorescein treponymal antibody absorption tests, and check for HLA-B27 antigen, which is a common cause of autoimmune presentations. If the inflammation is granulomatous, you can also work up for ANA, rheumatoid factor, and ACE, which is an angiotensin converting enzyme. To rule out sarcoidosis, PPD and controls for TB, herpes simplex and zoster titers, ELISA for Lyme disease, and HIV workup as well. Do chest radiographs to also rule out sarcoidosis and TB, which can show up as infiltrations in the lung area, chest CT, and sacroiliac X-ray for ankylosing spondylitis, knee X-rays for Reiter syndrome. Urinalysis is to rule out interstitial nephritis, and cultures of the urethra to also rule out Reiter syndrome. Reiter syndrome, by the way, is a type of arthritis that causes redness, heat, swelling, and pain in the joints. And it can have eye inflammation, low back pain, and skin problems, as well as enthesitis. These probably do sound familiar from the earlier part of the presentation. These are the treatments for GI-induced anterior uveitis. We can use topical steroids to calm down the inflammation in the eyes. This is done by applying prednisolone acetate 1% every hour, then tapering very slowly when the inflammation is grade 1 or less. IOP, because the inflammation tends to swell up the tissue, that can raise the pressure within the eyes. So closely monitoring the intraocular pressure is very important. Topical cycloplegics like scopolamine 0.25% and cyclopentolate and tropicamide is another effective method to control the IOP. And for Lyme disease, TB, syphilis, Whipple's, and toxoplasmosis, systemic antibiotics can be applied. Depending on the presentation and the workup result from the investigations, also consider topical antivirals and systemic antivirals. If the presentation is severe, look into oral steroids and accompanying PPI or H2 to control reflux. For anterior uveitis presentation that is resistant to these options, and for critical stages that involves macular edema, we could consider subtenons or intravitreal steroid injections with triamcinolone acetonide, 40 milligrams per milliliter. Some of the alternative agents other than steroid are NSAIDs, immunosuppressive chemotherapy, and antimetabolites like azathioprine, methotrexate, and mycophenolate mofetil. Because the whole underlying cause is immune-mediated, inhibitors of leukocyte signaling can be effective in preventing progression of uveitis. This includes the administration of cyclosporin, tacrolimus, in doses dependent on the body weight of the patient. Oculating agents like cyclophosphamide is also effective against a lot of autoimmune presentations. And that goes similar in effect with biologic agents. These are also effective in autoimmune presentations like rheumatoid arthritis. Dapsone can also be used to treat skin manifestations of IBD. Prognosis of GI-induced anterior uveitis is etiology dependent. So if it is well controlled in terms of inflammation, the prognosis is good, and it can also be poor if the anterior uveitis coexists with cataracts, glaucoma, posterior synechia, or the contact between the lens and the iris, band keratopathy, iris atrophy, cystoid macular edema, retinal detachment, optic neuritis, or even neovascularization. So here is the review of the comparison slide and the linking slide between gastroenterology and ophthalmology. Here is the summary chart of everything we talked about so far. Here's the reference list from which we drew all the information used to make this PowerPoint. Thank you for watching this video.